Hi guys, welcome back to G Chats with your host G. We are back in the G spot, and in today's episode we are talking about something that has been so highly requested by each and every single one of you, and that is Ureaplasma and Mycoplasma. And it's not a happy topic because so many of you are struggling with these bacterial infections, and we need to talk about it because there's not enough information on it. So I'm really excited to really just jump right in. I don't want to waste any time. This isn't going to be a super long video because I'm going to get straight to the point with this information. I'm going to talk about what it is, how you get it, and how you can treat it. Those are the very specific things that I feel like everybody needs to know in the burning question, and kind of just get rid of the stigma around ureaplasma and mycoplasma. They're not talked about enough. So many women don't know about it. So without further ado, let's get into it. So ureaplasma and mycoplasma are a type of bacteria. Now, what's special about ureaplasma and mycoplasma is that they do not have a cell wall. So 90% of bacteria does in fact have a cell wall. Ureaplasma and mycoplasma are one of those pathogens that don't have a cell wall. And so because of this, they get put in this family, this unique bacterial family class as mollicutes. So mollicutes are bacteria that don't have a cell wall. That includes these two. And so knowing and understanding this is very important because this lack of a cell wall makes the bacteria more difficult to diagnose and harder to treat. So it's more difficult to diagnose because they don't show up on standard cultures. So when you get like a vaginal swab done, right, we can like put the swab on an agar plate, put it in an incubator and let it grow, right? And we can see what bacteria grows on this plate. But when it comes to ureaplasma and mycoplasma, this lack of cell wall really does prevent it from actually showing up on cultures. And so the best way to diagnose somebody or find out if somebody has ureaplasma or mycoplasma is through a PCR test or a NAT test. And so these two tests are really the only way that we know or that it'll show up that somebody has ureaplasma or mycoplasma. And so a lot of times the issue is this persistent symptoms that are so similar to BV often gets mistaken for BV, and BV is the only thing that's treated. And we'll talk a little bit about the connection between ureaplasma, mycoplasma, and bacterial vaginosis because they're so deeply connected. And this is where clinical treatment is failing women who are struggling with ureaplasma and mycoplasma, and oftentimes don't even know that they have the pathogen. So the issue is it's harder to detect, and then it also is harder to treat. And that is, again, the reason why it's hard to treat is because of the lack of a cell wall. So as I mentioned, most bacteria does contain a cell wall. And so there are a bunch of antibiotics that work by breaking down the cell wall and attacking the cell wall of bacteria. So because these pathogens, molecules, do not have a cell wall, this means that antibiotics, and specifically, like, for example, a class of antibiotics that do not work on molecules is beta-lactams, and that includes penicillin, amoxicillin. These antibiotics do not work against molecules because the way that they are designed and engineered is to be able to attack the cell wall. But if a bacteria doesn't have a cell wall, then they can't get rid of the bacteria. So for that reason, ureaplasma and mycoplasma need specific antibiotics in order to be treated, right? So you can't just use amoxicillin, penicillin, and you can't just use metronidazole and sometimes even clindamycin. There's certain drugs that ureaplasma and mycoplasma need in order to be killed off. Now, while there are antibiotics and a bunch of antibiotics like beta-lactams that are created to disrupt the cell wall of the bacteria, and other antibiotics do have different ways of destroying the bacteria. Everything from the ribosomal DNA to the DNA itself, the structure, the proteins. There's so many different ways that antibiotics and different antibiotic classes work. So because of the unique structure of molecules, clinicians will use different antibiotics that can target these molecules in a different way that's not a cell wall. So it's not to scare you that, oh my God, no antibiotic works for it. There's just different antibiotics. And the key is knowing that you have ureaplasma and mycoplasma in order to get the right antibiotic prescribed to you. Because oftentimes there's like, oh, you have symptoms of BV, so I'm just going to give you BV medication. And that won't work against ureaplasma and mycoplasma. So understanding, oh, you have this bacteria, which means that it's a molecule, which means it doesn't have a cell wall, which means you need a different kind of or specialized kind of antibiotic. That's the key for successful treatment. So the first line of treatment is any kind of tetracycline. Usually it is doxycycline. I'm sure most of you have heard of it. And doxycycline works by inhibiting the ribosomal function. Then you have a macrolide. So if you are resistant to tetracyclines and doxycycline in particular, the second line of treatment will be a macrolide. And that could be something like azithromycin. You guys have probably heard of the Z-Pak. That's like the 5-day treatment of azithromycin. This works by inhibiting the protein synthesis. And then there's fluoroquinolones, and fluoroquinolones are the third line of treatment if the first and second line fail. And so these work by targeting the DNA replication. So different classes of antibiotics work on bacteria in different ways. So again, not the end of the world if you do have a molecule. It's just more important in understanding that you have this bacteria so that you could get accurate or like the appropriate antibiotic prescribed to you for appropriate treatment. So that's really important, and that is something that's missed. And it's missed because these pathogens are kind of in a gray area, if you will. So what do I mean? We're going to talk about some terminology now. And the three things that I want to cover is commensal bacteria, opportunistic bacteria, and sexually transmitted bacteria. So definitions do matter, okay? And this is not talked about enough because I think we get in a habit when we're talking about the vagina, the urinary tract for years and years and years. People think that like our urine is sterile. People think that our vaginas need to be sterile. Nowhere in your body is sterile. Nowhere in your body is sterile. You have bad bacteria on your hands right now as you're watching this video. There's bad bacteria in your gut. There's bad bacteria on your skin. There's bad bacteria literally everywhere. The reason why you're not falling apart and shouldn't be falling apart is because your body is supposed to be able to withstand these bad guys. But these bad guys naturally live on our body. Now, the key is that these bad guys living on our bodies, in or on our bodies, without doing a singular thing because good guys are there protecting us, this makes them commensal. So commensal bacteria is bacteria that can live naturally on the body and not do a single thing. They're not good bacteria, but they just don't bother you. They don't do anything. They just sit there and they chill and they can live alongside good bacteria. Then we have opportunistic bacteria. Opportunistic bacteria is bacteria that lives alongside good bacteria and they don't do anything. They cause no harm unless you lose the good bacteria, unless they have the opportunity to cause problems. And where the opportunity is when good bacteria dies off. And I'm talking especially within the vagina. So opportunistic pathogens are pathogens that want to take the opportunity or have the opportunity. And the only way in the vagina that they have this opportunity is when you lose the good bacteria. And then we have sexually transmitted bacteria. And this is bacteria that is transmitted from one partner to another. It's that simple. Now, the key with ureaplasma and mycoplasma is that they actually check off all three boxes. In some people, ureaplasma and mycoplasma is commensal. This means that they just live in the vagina. Some people naturally have ureaplasma and mycoplasma in their genital tracts, and it does absolutely nothing. They have a dominating presence of lactobacillus, of this good bacteria, and the ureaplasma and mycoplasma are just chilling. They're not doing anything. but they are also opportunistic, meaning that if you have ureaplasma and mycoplasma chilling in your vagina and they're not doing anything, if you happen to lose your good bacteria, your defenders, your military defenses, if you happen to lose these guys, unfortunately, this is where ureaplasma and mycoplasma typically start to cause problems. They start to cause the inflammation, the uncomfortable symptoms, and start to create biofilms and all of these things. And we'll talk about biofilms in a little bit, but they start to cause problems. And it's now because they have the opportunity to. And they can be passed from partner to partner. So ureaplasma and mycoplasma fall into this gray, confusing area in the medical field and even with patients because they check off all three boxes. They literally meet all three. They're commensal, they're opportunistic, and they can be passed between partner and partner. And this is super important to understanding because, as I mentioned, opportunistic. They have to have the opportunity. And this is actually where bacterial vaginosis comes into play because this is exactly why ureaplasma and mycoplasma are almost always found alongside BV or chronic BV sufferers. And that is because in order to have the opportunity to grow, in order for ureaplasma and mycoplasma to have this opportunity to flourish and cause problems, you have to have a deficiency of lactobacillus. You have to lose this lactobacillus. And what we know, and I cannot state this enough, I say it all the time, bacterial vaginosis is a condition, not something that you would just say like, oh, this is an infection. It is a condition. And the condition is when the vaginal ecosystem is imbalanced. It's off. And what do I mean when I say imbalanced and off? I mean the deficiency of lactobacillus. BV is classified as a loss and a deficiency of lactobacillus. This deficiency of lactobacillus allows, yet again, the commensal bacteria, the Gardnerella, anaerobic bacteria. So when we're talking about BV, anaerobic bacteria lives inside of the vagina. It is normal. This is commensal. Things like Gardnerella, Prevotella, these pathogens are commensal. They live in our vaginas, but in really small amounts, and they don't do a single thing unless we lose our good guys. So once we lose the good guys, now these bad guys that naturally live in our vagina, these anaerobes, they overgrow and now they cause problems. They cause anaerobes are what's responsible for that fishy odor. So they give you that fishy odor, that discharge, the inflammation, the burning. So you have all these uncomfortable symptoms. But you also now, if you have ureaplasma or mycoplasma that's commensal in your vagina, now that you lost this good bacteria, now with all this inflammation and these inflammatory responses, they're going off. Now ureaplasma and mycoplasma also have the opportunity to grow and cause problems. So now you are in this state where you're going to the doctor and what's likely being caught by your physician is BV. They're catching that you have the BV condition. And so they're treating you with BV, but what happens is what gets left out of the treatment of bacterial vaginosis is restoring the ecosystem, but it's also hard to restore if you have this overgrowth of mycoplasma and ureaplasma as well. So now, even if you're killing all these anaerobes and you still have ureaplasma, mycoplasma flourishing, and then even if you try to take probiotics, but these guys are still colonizing your vagina, it makes it harder for the probiotics to compete. And so a lot of people don't even know that they have ureaplasma or mycoplasma. It gets missed. And that is why so many people who have ureaplasma and mycoplasma infections have it alongside bacterial vaginosis. They usually are present together, and that is because the entire vaginal ecosystem is thrown off. And this entire ecosystem being imbalanced allows all of the bad guys to start flourishing. And what we also see is that up to 70% of women who have bacterial vaginosis are asymptomatic. So I personally don't like to go off of just symptoms. That's not how I look at science. Like, oh, if you're having symptoms, then do X, Y, and Z. I think that standardized testing should include testing for good bacteria, because what we have to look at is the entire ecosystem, because the presence of these pathogens alone does not equal infection. The presence of Ureaplasma, Mycoplasma, Gardnerella, the presence of these bad guys does not mean that you have an infection unless you have a deficiency of lactobacillus. And in many cases, some women are asymptomatic. They're not having burning, itching, discharge, odor. They're not having these symptoms. So if they're not having these symptoms, there's no way that they know that they're having this ecological imbalance going on, this ecosystem. I said ecological, ecosystem imbalance. They don't know that. So it should be tested, and I think it should be regular testing. I think when you go in for your pap smear, the way it's like a standard regular thing, I think swabbing the vagina for good bacteria should be a standard normal thing that we do in the OBGYN office. I don't understand why we don't do it. It should be the standard. And so again, a lot of women are asymptomatic, so they don't even know that they're having an imbalance in their vagina. And so if they do have intercourse with somebody, with a partner who does or is a carrier of ureaplasma and mycoplasma, because they have this imbalance in their vagina without them even knowing, now that introduction of this pathogen causes problems. Now they start having problems. They're like, oh my God, I've never had any issues, and I slept with this one person and now I have problems. And that is where people go crazy, that like ureaplasma, mycoplasma are STIs. But remember, while they are sexually transmitted, they don't cause infections just by exposure. They do not cause infection by exposure. They cause infection by an ecosystem imbalance. And that is super important to understand when we're talking about stigma and trying to like offer better treatment and like change the space. You know, putting these titles that aren't accurate and saying it's an STI is not helpful. It's not helpful. Now, in some cases, yes, ureaplasma and mycoplasma might be able to cause problems when you do have lactobacillus, and you could contract it via sex, right? But the difference, and this is why I'm very careful with like labeling and rushing to label things as STIs, because chlamydia, gonorrhea, these things do not live in our vagina. Syphilis, they do not live in our reproductive tract at all. They don't belong in our vaginas and our uterus and our cervix. They don't belong in our vaginas at all in any capacity, to any amount. They do not belong in the vagina. So ureaplasma, mycoplasma, and even BV pathogens do not compare to sexually transmitted infection pathogens, because these guys like chlamydia and gonorrhea, they don't belong in our vaginas. And once they are in our vaginas, they cause problems. They wreak havoc. That's why leaving STIs untreated is serious, because they can cause serious damage to your reproductive organs. They do not belong in the vagina. Unlike ureaplasma, mycoplasma, and BV pathogens, they're commensal. We can have them in our vaginas and there's no issues. Like, they can exist and it's normal for them to exist. Everybody has good and bad bacteria on their bodies. And so for that reason, we have to be careful with quickly jumping the gun and calling things STIs and things like that and saying, oh, it's the man that you're with. There's people in monogamous relationships who randomly have this problem. And what they don't know is that they probably had ureaplasma, mycoplasma in their vaginas for years and nothing happened, because they had a good balance between the good bacteria and the bad bacteria. And maybe 10 years went by, they're getting older, they lost this good bacteria due to antibiotics, the soaps that they used, all types of things. They lost this good bacteria, and now losing this good bacteria is what allowed the ureaplasma and mycoplasma to overgrow, and not that their partner stepped out of the relationship and gave them an STI. That's really important to understand, and that it's honestly not about defending anybody. It's about giving people the right information so that we can treat people better, so that we can give people better information, better education, better access to certain tests that they need to do and things like that. It's not about like scaring people and creating narratives. It's about giving people the right information. So BV, as I said, and Ureaplasma, Mycoplasma are usually found alongside each other for these reasons that we discussed. Now, the important and burning question is, okay, Gianna, so I had BV, right? If my ecosystem needs to be imbalanced in order for me to get Ureaplasma and Mycoplasma, but my doctor obviously found BV first because it's the easier infection to discover. So I took my metronidazole or my clindamycin, and I still feel like crap. I'm still having all the symptoms, and now I'm raising an eyebrow thinking, oh, it's Ureaplasma or Mycoplasma. And they did confirm it, but now it's persistent. It won't go away. How do I fix the problem? So I've recommended in the past for people who have persistent BV infections, I've always said that it's likely due to a biofilm. So we know that Gardnerella, an anaerobic bacteria that's associated with bacterial vaginosis, do in fact grow and cause a biofilm, which is the sticky, slimy coating that protects the BV pathogens, and it makes it harder for antibiotics to get to what it needs to get to kill off the pathogens. So remember, as we discussed, some antibiotics get to the protein, some of them get to the ribosomal DNA, like they work in different ways. If a biofilm is present, it can make all of that much more difficult. And so for that reason, biofilms are increasingly becoming a problem and treatment is failing. And so many women are stuck in this endless cycle of, I took my antibiotics and I'm still not feeling better. Why? What do I do? And I always recommend that we need to do a 3-step method for bacterial vaginosis. So remember, this is for BV first. We need to disrupt that biofilm. Then we need to attack the bad guys with antibiotics. And then we need to solve the root of the problem, which isn't the biofilm. It's not the overgrowth of the bad bacteria. It is the lack of good bacteria. So you're going to have to get the good bacteria back into your vagina. So for step 1, to disrupt the biofilm for BV, I've always recommended either boric acid or lactic acid gels. These two options are great for disrupting the biofilm and penetrating that biofilm, and especially boric acid because it's a cell wall disruptor. So it can really, really help with biofilms that are associated with BV pathogens. And we know that research does back this. There's enough research to highlight this. So using boric acid for 5 to 7 nights before your antibiotics, and then you start your antibiotics, whether it's oral antibiotics or vaginal antibiotics, you start your antibiotics to kill off. Now you release or remove that biofilm, and now you have the bacteria exposed, right? And you can actually get the antibiotics to do what they want to do. So then you do the antibiotic therapy, and then either you can begin your probiotic treatment while you are on your antibiotics. I just always recommend to space it out either 2 hours after or 2 hours before your antibiotic dosage. So like midday, usually if you're given oral antibiotics, they will tell you to take it in morning and night. So like midday, take your probiotics, or you can wait until after your antibiotic therapy and you can start your probiotic therapy to bring the good guys back into the vagina. So that is the 3-step method that I typically recommend for people with bacterial vaginosis. However, as you may have guessed, the reason why I discussed this and I brought this up is because while this is a great method, and biofilm disrupting agents like boric acid and lactic acid are great for BV associated pathogens, unfortunately, they're not so great for Ureaplasma and Mycoplasma. And boric acid does have antifungal properties and it's antiseptic. Like it does do a good job of like wiping the vagina clean, which is actually why I don't like boric acid when women are saying, oh, use it after you have sex or after your period to freshen up, because boric acid can actually kill off good bacteria as well. So it is antiseptic. Like it can kill off a whole lot of things, but molecules in particular are much more stubborn, and that is because they can survive a broader pH range and they don't respond to pH changes the same way that anaerobes do, and their biofilms are much more persistent. We see that in research. Molecules form a much stronger biofilm. So boric acid does lower the pH. So when you have like an entire ecosystem shift with anaerobes overgrowing and a lack of lactobacillus, like you're missing this good bacteria, your pH is higher. It's likely above a 5 or a 6, like it's above it. And so boric acid will bring it back down to like a 5.5, but that's still not as acidic as you want the vagina to be, which is why I tell my customers like reach for lactic acid as well to get the vagina into the range that you need it to get to. Lactic acid is the exact acid that your vagina needs. And this also promotes the growth of good bacteria, lactobacillus. So while yes, lactic acid and boric acid are great for BV-associated pathogens, mollicutes are more resilient to the pH. They don't really care much. Like they're like, oh, we're still going to thrive. Even if it's a little acidic, we're still going to thrive. They're more stubborn. And so for that reason, I recommend enzyme-based biofilm disruptors. And so enzymes are very popular. You know, a lot of people think that eating a bunch of pineapples is going to make your vagina smell and taste good because of the bromelain that's in it, the enzyme that's in it. We see enzyme cleansers for your face. Enzymes are particularly popular, but when it comes to the vagina, there are promising research papers that are showing that enzyme-based biofilm disruptors can be helpful for mollicutes. So some of the enzymes include serrapeptase, and serrapeptase works by breaking down the protein structures within the biofilms. There's nattokinase, which breaks up the fibrin, which is a common part of the biofilm scaffold. There's DNase, which targets the extracellular DNA that bacteria uses to stabilize the biofilm. And then there's proteolytic enzyme blends, which targets multiple matrix elements like the protein, the polysaccharides, and the DNA. So those are just a few enzymes, just to name a few, that you should look for and maybe search for. There are biofilm disrupting products on the market. I know Kirkland has a biofilm disrupting product. So if you are someone struggling with ureaplasma, mycoplasma, you've taken antibiotics for it and you've seen no success with the antibiotics, you could start looking into a biofilm disrupting agent, specifically a digestive enzyme. This is very helpful. Now, if you are someone who's been diagnosed with both ureaplasma, mycoplasma, and bacterial vaginosis, you can simultaneously use the digestive enzymes with boric acid to feed two birds with one scone. So you can do that and then take your antibiotic therapy, but you're likely going to be on a super long course of antibiotic. I mean, not super long, but they'll likely do metronidazole first or clindamycin first for your bacterial vaginosis. And then they will try to treat the molecule infection with, as I talked about, doxycycline, for example. So you're going to want to do that. And then you're going to want to introduce antibiotics. And then you're going to want to introduce probiotics into your routine. That is the best way that I recommend attempting to clear ureaplasma or mycoplasma. But this was a simple guide, if you will, to ureaplasma and mycoplasma. I hope that you guys were able to, from this video, understand ureaplasma, mycoplasma, and bacterial vaginosis and understand your body. It's very important to advocate for yourself. And I just want to bring this up. As I mentioned in this video, ureaplasma, mycoplasma go kind of hidden and under discussed, especially in the doctor's office, because a lot of doctors won't test for this unless you literally push them to. The reason why I make these kind of videos and talk about these things is so that you guys have this information and you can advocate for yourself within the doctor's office. I wish I could be there and advocate for you guys and be yelling at the doctors, yelling at the nurses and saying like, come on, we got to test for this, this, and this, and like guiding them on what to test for. I can't. So I give you this information. Your biomedical engineering big sister gives you this information so that you can understand your body better. Take this information to your doctor and advocate for yourself. So if you're someone who's been diagnosed with BV or maybe even a yeast infection, guys, you've been diagnosed with either of these vaginal infections or even a UTI over and over and over again, and you feel like it won't go away. I'm having burning while I'm peeing. I am having all these symptoms, the burning, the discharge, all of that, the odor. If you're having all of these urinary and vaginal symptoms and you've been treated over and over and over and over again and it's not going away, push to get tested for ureaplasma and mycoplasma. Push, push, push. Ask your doctor to test you for these things. That way you can see, or at least rule it out. Because if you can rule out ureaplasma, mycoplasma, maybe it's bacterial vaginosis that developed a biofilm. Maybe it's a UTI that's developed a biofilm. Maybe it's a yeast infection that developed a biofilm. And when I'm saying all these things like yeast infection, I'm talking about Candida albicans, like the popular ones. So, because ureaplasma can, in some cases, infect the urinary tract, which ultimately causes a urinary tract infection. But urinary tract infections are typically caused by E. coli, Klebsiella, Pseudomonas. So I'm more so like just picking on like the more common ones. So BV, it's caused by Gardnerella and anaerobic pathogens. So maybe those typical pathogens caused a biofilm, and then we need to focus on that and we can eliminate ureaplasma, mycoplasma. But then if you know, finally you get your answers that you have ureaplasma, mycoplasma, then at least you have this video to reference to be able to effectively treat it. Because as I mentioned, like these pathogens are difficult to treat. And in some cases, antibiotic resistance is growing for molecules. So even the first line of treatment of doxycycline, the second line of treatment of azithromycin, sometimes they don't work. They fail. And so this makes it more difficult to treat these infections and ultimately leaves you in this like endless cycle of feeling like your infection won't go away and you're on rounds and rounds and rounds of antibiotics, which makes antibiotic resistance even worse. So understanding your body, understanding biofilms, and I will say there is no like real like test that'll tell you you have a biofilm, right? There's no black and white test. This is more so off of persistence right now. Hopefully in the future, there's a test that can determine biofilm activity and we can like confirm that with a vaginal swab. But right now, persistence is kind of the key. So if you're someone that's on rounds and rounds and rounds of antibiotics and you're swabbing the vagina and it's coming back positive, the culture is coming back positive, or the PCR test is coming back positive, it's likely you have a biofilm, and you could target the biofilm in the ways that we discussed in this video. So I hope that you guys really enjoyed this video. I hope that it was super helpful. Let me know if you guys want any more information about ureaplasma, mycoplasma. I love you guys so much, and I will see you guys in the next one. Bye, guys.